Pathogenesis is all about the mechanisms that drive a disease's development. Today, we'll dive into the pathogenesis of diabetes, covering everything from type 1 and type 2 diabetes mellitus to gestational diabetes mellitus, and essential diagnostic tools like the oral and intravenous glucose tolerance tests. If you find this session helpful, make sure to like, subscribe, and share it with your friends. Let's jump right into type 1 diabetes mellitus. Type 1 diabetes is an autoimmune condition. Here, the body's own immune system mistakenly targets and destroys specific cells in the pancreas, called beta cells. These cells are crucial because they produce insulin, the hormone that helps control blood sugar levels. And without them, the body can't manage blood sugar effectively. This attack is primarily carried out by T cells. It's like the immune system is going to war with its own ally, without realizing the damage it's causing. But interestingly, only the beta cells are affected. Other types of cells in the pancreas, like alpha and delta cells, are usually left unharmed. Here's something surprising: this destructive process actually begins months, even years, before symptoms show up. For symptoms to start appearing, about 80 to 90% of the beta cells have to be destroyed. And the rate of this destruction varies. It often happens faster in children than in adults. Now, let's talk about antibodies. Antibodies play a big role in identifying type 1 diabetes and can even appear before any symptoms show up. 1. Islet cell cytoplasmic antibodies, ICAs. These antibodies are present in about 75 to 85% of newly diagnosed type 1 patients. They're detected through a process called immunofluorescence microscopy. But detecting them isn't easy, it's complex, labor-intensive, and tough to standardize. 2. Insulin autoantibodies, IAAs. IAAs are particularly common in young children under 5 with type 1 diabetes, showing up in around 90% of cases. Interestingly, these antibodies can appear even before diabetes fully develops. However, they might also form after someone starts insulin therapy. 3. Glutamic acid decarboxylase, GAD65, antibodies. These antibodies can sometimes be detected up to 10 years before diabetes onset in about 60% of patients. They're also useful for identifying patients who may initially appear to have type 2 diabetes but actually have type 1. 4. Insulinoma-associated antigens, IA2A and IA2-beta-A. Present in over 50% of new diagnoses, these antibodies target specific enzymes, called tyrosine phosphatases, which are involved in the immune response. 5. Zinc transporter, ZNT8, antibodies. ZNT8 antibodies are found in about 60 to 80% of newly diagnosed patients and can show up in people who don't have other autoantibodies. They're the least understood of the antibodies involved in type 1 diabetes, but they're another key marker. Type 1 diabetes is influenced by genetics, but it's not as simple as inheriting a single gene. It's a complex, multigenic trait, meaning it involves multiple genes. HLA genes on chromosome 6 are the most significant genetic factors. In fact, about 95% of white patients with type 1 diabetes express specific HLA genes known as DR3 or DR4. But even identical twins, who share all of their DNA, have only a 30% chance of both developing type 1 diabetes, showing us that genes are only part of the story. Beyond genetics, environmental factors might play a role. Certain viral infections, like rubella, mumps, and Coxsackie virus B, have been linked to type 1 diabetes. Some researchers also believe that early exposure to cow's milk may contribute, although this idea remains debated. One big question is whether we can screen and prevent type 1 diabetes. Currently, screening for autoantibodies is controversial. Even if someone tests positive for these antibodies, there's no guaranteed way to prevent the disease from progressing. 1. Primary prevention. This type of prevention focuses on individuals who have genetic risk factors but no signs of disease. Some trials are exploring dietary changes, like adding omega-3 or vitamin D supplements, to reduce risk. 2. Secondary prevention. Secondary prevention targets people who already have persistent autoantibodies, with treatments like immunosuppressive therapy aimed at delaying the disease. 3. Tertiary prevention. This approach focuses on preserving the remaining beta cell function in patients who have been newly diagnosed, using different therapeutic strategies. However, long-term success in preserving beta cell function remains elusive. Some experts suggest that combining immunomodulation and immunosuppressive therapy might hold the key to protecting beta cells over the long term, but this is still under research. Type 2 diabetes affects millions globally, but understanding the roots of this condition can be complex. Two main problems define type 2 diabetes: insulin resistance and beta cell dysfunction. Insulin resistance, or the body's reduced ability to respond to insulin, is often considered the primary issue. Over time, however, the pancreas can't keep up, leading to a gradual decline in insulin production. This results in a relative insulin deficiency early on, which may progress to a full deficiency as the disease advances. As insulin resistance increases, beta cells in the pancreas are pushed to their limits. Over time, this demand causes them to wear out and malfunction. They eventually lose their ability to respond to glucose levels, a condition known as selective glucose unresponsiveness. High blood sugar, or hyperglycemia, further impairs beta cell function in a phenomenon known as glucotoxicity. Fortunately, lowering blood sugar can reverse some of this damage. But there's more. Increased free fatty acids in the blood also play a role, contributing to beta cell failure in a process known as lipotoxicity. So, what is insulin resistance exactly? It's when the body doesn't respond to insulin as it should, even though there's plenty available. It's a common feature in obesity and type 2 diabetes, though we're still not completely sure what causes this defect in insulin action. To measure insulin resistance, we can look at fasting insulin levels or use specialized tests like the euglycemic insulin clamp test, which provides an indirect measure of the body's sensitivity to insulin. Insulin resistance isn't unique to type 2 diabetes. It appears in several other conditions too. 1. Type A insulin resistance syndrome. This syndrome is marked by high insulin levels, acanthosis nigricans, and hyperandrogenism, often affecting women. 2. Metabolic syndrome, Syndrome X. Metabolic syndrome includes insulin resistance, obesity, high blood pressure, and abnormal cholesterol levels, all of which increase the risk of cardiovascular disease. Key diagnostic features include an increased waist circumference, high triglycerides, low HDL cholesterol, elevated blood pressure, and high fasting glucose. Environmental factors play a big role in type 2 diabetes. Diet and physical inactivity are major contributors, and obesity is a top risk factor. While not everyone who is obese will develop diabetes, most people with obesity are insulin resistant. Both genetic factors and the duration and location of body fat play a role here, with studies like the Nurses' Health Study showing that obesity is one of the strongest predictors of type 2 diabetes. Fortunately, lifestyle interventions can make a difference. Regular exercise significantly boosts insulin sensitivity and can reduce type 2 diabetes risk by up to 58% in people with prediabetes, regardless of their weight or family history. Genetics play a strong role in the development of type 2 diabetes, although it's not a simple inheritance pattern. In fact, studies on identical twins show nearly 100% concordance for the disease, meaning if one twin has it, the other almost certainly will too. 1. Multifactorial inheritance. Unlike single-gene disorders like cystic fibrosis, type 2 diabetes involves multiple genes that interact with environmental factors, such as diet and physical activity. 2. Specific genetic mutations. Rare mutations in certain genes, like those for insulin receptors, can lead to extreme insulin resistance. However, these cases are rare, and the genes that increase diabetes risk generally have a modest effect. 3. Genome-wide association studies, GWAS. Over 60 genetic loci have been identified in relation to type 2 diabetes, mainly linked to insulin secretion rather than resistance. However, these genetic factors only explain about 5% of type 2 diabetes cases. For maturity-onset diabetes of the young, MODY. MODY is a rare, inherited form of diabetes that resembles type 2 but occurs in younger, non-obese patients. When it comes to diagnosing diabetes, we've come a long way. From simple blood sugar tests to advanced methods like HbA1c, today we'll explore how diabetes is identified, the different types of tests used, and why they matter. Historically, diabetes diagnosis was straightforward. It was based solely on hyperglycemia, or high blood sugar levels. Everything changed in 2009 with the introduction of HbA1c, a test that measures blood glucose levels over time. HbA1c is especially useful because it reflects a person's average blood sugar over the past 2 to 3 months, making it ideal for long-term monitoring. In type 1 diabetes, diagnosis is usually straightforward, as the hyperglycemia is sudden and severe. But in type 2 diabetes, the progression is slower, making it harder to detect early. Back in 1979, the diagnostic criteria were primarily based on high plasma glucose levels, and these included 3 key indicators. 1. Classic symptoms of diabetes along with elevated plasma glucose. 2. Fasting plasma glucose, FPG, of 140 mg per deciliter, 7.8 millimoles per liter, or higher, observed on multiple occasions. 3. A 2-hour post-load glucose concentration of 200 mg per deciliter, 11.1 millimoles per liter, or higher during an oral glucose tolerance test, OGTT. These early criteria had some challenges. For instance, the OGTT, or oral glucose tolerance test, was more sensitive than fasting glucose for detecting type 2 diabetes in its early stages. This led to cases where individuals had high post-meal glucose levels but normal fasting glucose, making diagnosis tricky. In 1997, the criteria were revised to improve early detection. The fasting glucose threshold was lowered from 140 mg per deciliter to 126 mg per deciliter, 7.8 to 7.0 millimoles per liter. The goal? To catch diabetes sooner and start treatment earlier to reduce complications like retinopathy and nephropathy. Today, a fasting plasma glucose level of 126 mg per deciliter or higher on multiple occasions is considered diagnostic for diabetes. But fasting hyperglycemia can develop later in type 2 diabetes, sometimes delaying diagnosis. By the time of diagnosis, around 30% of patients already have complications like retinopathy or neuropathy. This is because type 2 diabetes often develops silently for 4 to 7 years before clinical diagnosis. To catch diabetes early, the American Diabetes Association, ADA, recommends screening for all asymptomatic adults starting at age 45. However, those with risk factors, like a family history of diabetes or obesity, should start earlier. Screening should be repeated every 3 years, though the benefits of screening alone remain debated. The OGTT measures how the body processes sugar by checking blood glucose before and 2 hours after an oral glucose intake. While it's more sensitive than fasting glucose alone, the OGTT is not frequently used in the US due to its inconvenience and variable results. 1. Sensitivity. OGTT is more sensitive than fasting glucose, but about 20% of tests can yield non-diagnostic results, where only one sample shows elevated glucose. Because of this, it's recommended that abnormal OGTTs are repeated for confirmation. 2. Testing process. Before taking the OGTT, certain conditions should be met. The patient should avoid medications affecting glucose, maintain a normal diet, and fast for 10 to 16 hours. 3. Procedure. Adults drink 75 grams of glucose in 300 milliliters of water, and their blood glucose is measured after fasting and then 2 hours after drinking the solution. Although not common, OGTT is used in specific situations. 1. For diagnosing gestational diabetes in pregnancy. 2. In postpartum screening for women who had gestational diabetes. 3. To diagnose impaired glucose tolerance, even though this doesn't always correlate with impaired fasting glucose. 4. In cases with unexplained complications like retinopathy, neuropathy, or nephropathy despite normal random glucose levels. 5. For large-scale studies to gather population data. Another test, the intravenous glucose tolerance test, or IVGTT, is used when the OGTT isn't practical, such as for patients who can't tolerate oral glucose due to digestive surgery. This test introduces glucose directly into the bloodstream. 1. Preparation. Preparation for IVGTT is similar to the OGTT, including diet and fasting requirements. 2. Procedure. A glucose dose is given intravenously over 3 minutes, and blood samples are taken every 10 minutes for an hour to track glucose levels. This test can measure insulin levels directly and determine the rate of glucose disappearance in the bloodstream. 3. Interpreting results. Results are plotted to measure glucose clearance, with a rate called K that indicates how quickly glucose is cleared. Values below 1% suggest diabetes. Like OGTT, IVGTT results tend to worsen with age, indicating that glucose tolerance naturally declines over time. Gestational diabetes mellitus, or GDM, is a condition that affects thousands of pregnancies each year. Today, we're exploring what makes GDM unique, who's at risk, and the importance of managing it to ensure a healthy pregnancy for both mother and baby. Pregnancy naturally increases insulin resistance, especially in the late second and third trimesters. To maintain normal blood sugar levels, or euglycemia, the body usually produces more insulin. But in some women, this increased demand leads to gestational diabetes because their pancreas can't produce enough insulin. Some women are at a higher risk of developing GDM. Risk factors include 1. A family history of diabetes, particularly in first-degree relatives. 2. Obesity and advanced maternal age. 3. Glycosuria, or glucose in the urine. 4. A history of adverse pregnancy outcomes, like stillbirth or having a large baby, also known as macrosomia. Screening for gestational diabetes has evolved over the years, with guidelines developed in workshops from 1984 to 2007. Screening practices vary widely, ranging from no screening in some countries to selective or even universal screening in others. 1. Common tests include fasting glucose, random glucose, or an oral glucose tolerance test, also known as OGTT, where blood sugar is measured after consuming glucose. 2. The OGTT is often the preferred method, and the diagnostic criteria are based on guidelines originally set by O'Sullivan and Mahan in 1964. There's been a lot of debate around the specifics of diagnosing GDM. Disagreements exist over the glucose load amounts, 75 grams or 100 grams, test duration, 2 or 3 hours, cutoff values, and the number of abnormal readings required for a diagnosis. Historically, diagnostic criteria focused more on predicting future risk of diabetes rather than pregnancy outcomes. However, that changed after the HAPO study. The HAPO study was a large-scale investigation involving over 23,000 women. It revealed that even slight increases in maternal blood sugar levels could impact pregnancy outcomes, such as macrosomia, or large birth weight, neonatal hypoglycemia, cesarean section, and preeclampsia. This study showed that each value measured in an OGTT, fasting, 1 hour, and 2-hour glucose levels, contributed independently to pregnancy risks, without clear thresholds. Following the HAPO study, the International Association of Diabetes and Pregnancy Study Groups, IADPSG, recommended new diagnostic criteria for GDM. Under these guidelines, GDM can be diagnosed if any of the following OGTT values are met or exceeded: fasting glucose at or above 92 mg per deciliter, 1-hour glucose at or above 180 mg per deciliter, or 2-hour glucose at or above 153 mg per deciliter. These updated guidelines could increase GDM prevalence from 7% to as high as 18% in the US, but not everyone has fully adopted them. While the American Diabetes Association, ADA, World Health Organization, WHO, and other countries support these guidelines, some organizations like ACOG and the NIH are hesitant. Concerns include the potential costs and the lack of strong evidence that earlier diagnosis improves long-term outcomes. GDM can lead to complications for both the baby and the mother. 1. Increased risk of neonatal mortality and morbidity, including hypoglycemia and macrosomia. Macrosomia is common because maternal high blood sugar stimulates excessive fetal insulin production, which promotes growth. 1. Higher rates of cesarean delivery and pregnancy-related hypertension. 2. GDM also significantly raises a mother's risk of developing type 2 diabetes after pregnancy by 7 to 12 times. Postpartum care is crucial for women who've had GDM. They should undergo diabetes screening 6 to 12 weeks after giving birth and have regular checkups every 3 years. If their blood sugar returns to normal, routine glycemic assessments using fasting glucose or HbA1c can help monitor their risk. For women who already have diabetes before pregnancy, the risks are even higher. Pre-existing diabetes increases the chance of congenital malformations in the baby, but tight blood sugar control during the first 8 weeks of pregnancy can reduce this risk. Interestingly, while animal studies have shown that maternal hypoglycemia can cause birth defects, this doesn't seem to apply to humans. That's a wrap on today's session. If this was helpful, please like, subscribe, and share it with others. Thanks for watching, and I'll see you in the next one. Keep studying, bye.